Welcome to the Guide Academy course, Why Did My Patient Just Code? The purpose of this course is to help new and experienced anesthesia providers learn from others' experiences and be able to preemptively identify and avoid reasons that are common to complete cardiovascular collapse. Unfortunately, fortunately, these events are uncommon. But that means that we sometimes can get very comfortable and miss the signs that we ought to be looking for them and make mistakes that are avoidable and can lead us down a path that ultimately can lead to a negative patient outcome. Let's start with a very common experience. We have a patient, they're in the EP lab for an ICD implant for primary prevention. The chart doesn't have much information. The patient just needs an ICD, and it does say primary prevention. So you decide propofol for moderate deep sedation. This is very common, probably a good plan. However, shortly after the case is started, the systolic blood pressure drifts down into the 70s. So what drug do you push? You push epinephrine, phenylephrine, milrinone, norepinephrine, vasopressin. Think about what would be best for this patient in this case. ICD for primary prevention. And what did we have? We had a blood pressure in the 70s, heart rate, AFib in the 70s. So now let's imagine that you gave phenylephrine. You thought my heart rate 70, I don't want tachycardia, I already have a bag of Neo mixed up. The pressure improves. But then the sats begin to drift down. The blood pressure drops. You give some Neo, the heart rate drifts, and then before you know it, you're troubleshooting the pulse ox because you don't have a signal, and you realize you're in PEA. What happened? So what did happen? Did we have biventricular failure, pulmonary embolism, myocardial infarction, or sometimes what we often want to say and miss the opportunity to think about what precipitated the event. We're tempted to just say, it was a sick patient, problems happen. Think about it. What happened in this case? You had a patient ICD, pressure drifted down, you gave him Neo, pressure came back, and then sats dropped. Heart rate dropped, pressure dropped to code. Well, if we were to drop a TEE on this patient, we'd probably see something like this as the code was developing. So you see a patient with an ICD implant for primary prevention. That means they are at risk of malignant ventricular arrhythmias, like VT, VF, but they haven't yet had one. So why would they be at risk? Well, the most common cause is just an ejection fraction of 35% or less. That in and of itself is an indication for an ICD or implantable cardioverter defibrillator implant. So this patient had low EF, and we gave them propofol, negative inotrope. And so as the pressure dropped, we increased the afterload further, or we increased the afterload that would basically strain an already strained and weakened heart. You might get an increase in blood pressure temporarily, but at the expense of a severe drop in cardiac output. So basically, you have to anticipate what is going on inside the heart. I'm going to give you some tools throughout the rest of this presentation to help you do that better. Looking at the Frank-Starling curve actually gives us a really good sense of what happened. And it helps guide us in thinking about our anesthetics effects on all of our cases. So first, before we start talking about the detail of anesthesia's effects on Frank-Starling, let's remember what it is. So on the x-axis of the graph, you have end diastolic pressure, or you could just have preload. On the y-axis, you have stroke volume, which is obviously directly correlative with cardiac output. The idea is that in a normal, healthy heart, as you increase your preload, so as your heart gets more and more full, as the heart gets stretched, it's able to squeeze harder to get the blood out. That's really nice. The heart dynamically adjusts to the preload coming in. But as that curve gets flattened, and you can see that happens with reduced contractility, that's the line on the bottom, the amount of increased stroke volume or increased squeeze with increasing preload decreases. What actually happens is you get to a point where increased preload has no change on stroke volume. And then finally, you get to a point where increased preload actually decreases stroke volume as the wall of the LV and then eventually the RV is completely stretched beyond the ability for those muscle fibers to interact. So what happens is our drug that we were using in this case, propofol, took a patient that already had decreased function at rest. We gave it a very potent negative inotrope, propofol. We also, as the electrophysiologist or cardiologist was putting the wires in, you get ectopy. The wire stimulates the heart or tickles the heart, and you get some ectopy. You get some missed beats, so you get some increased preload without output. So you're effectively moving rightward on that curve. You probably have some volume going, some fluids, and sedation decreases your endogenous catecholamines, right? You sedate the patient. Maybe you gave them some fentanyl, which is a really potent sympatholytic. So the negative inotropy of propofol, the loss of of catecholamines and sympathetic input, all of that has the effect of flattening that curve. So what happened was this patient had lost cardiac output due to reduced contractility. And as a result, the blood pressure dropped. So when we treated the patient with phenylephrine, what happened? We increased the afterload, further increasing the ventricular and diastolic pressure. That's on the x-axis, right? So as we did that, the blood pressure went up, but not the cardiac output. And so let's go to the next slide and we'll see just what happened and the paradigm that we need to be thinking about. Well, I guess that next slide I was referring to is the next slide after this. The main point of all of this and the main point of that scenario is that we need to be thinking regularly in anesthesia about our anesthetic agents' negative inotropic effects, especially for patients with compromised cardiac function at baseline. For our young, healthy patients, it legitimately doesn't matter in most cases. The slight decrease in cardiac output, a slight decrease in contractility from a medication like propofol. They have so much reserves. And just the stress of surgery, the pain of surgery, and the catecholamines they produce, they take that normal Starling curve that you would have seen on that last slide and elevate it. So then you're nowhere near the heart failure curve, the flat one, or the cardiogenic shock, an even flatter curve. However, when you have compromised cardiac function at baseline, we have to be thinking about our anesthetics' negative inotropic effects, or we are going to face unsuspected, or we'll face surprise codes, decompensations, and even just problems like low urine output, slow mentation, and slow time to awake. This is why some of our patients, we end up in PACU, take that chest x-ray, and they have a pulmonary edema that seems quite a bit more than what they should have had given the 500 mLs or liter of fluid they got. What's been going on? Well, we put them into a low cardiac output state, cardiogenic shock, with our anesthesia. All right, so let's back out and do something. Think about something that you literally think about every case when you give a pressor, even if you don't realize what you're thinking about. You're thinking Ohm's law. Anytime when your blood pressure drops, you see that on the left side. If you don't like math, please don't turn your brain off. We'll walk through this nice and slow. Anytime this left side of the equation is low or high, anytime your blood pressure is low, you need to be thinking this is either a cardiac output or an SVR problem or both. Because MAP, or really MAP minus LV EDP, but we'll just think blood pressure, is equal to cardiac output times SVR, or flow times resistance. So where does cardiac output come from? So in this case, and actually in most cases, when you're dealing with heart patients, cardiac patients, you want to err on the side of thinking it's a cardiac output problem. And certainly in that scenario, it was. Cardiac output is stroke volume times heart rate. The heart rate component is very critical, especially in diastolic heart failure, where your cardiac output or your stroke volume is not your stroke volume, your cardiac output is heart rate dependent. No matter how long the heart fills in diastolic heart failure, the stroke volume is relatively fixed. Now, in most healthy patients, the slower the heart rate, the more filling time, so the longer the stroke volume, so that's dynamic. But in this case, where we were talking about a systolic heart failure patient, an EF of less than 35, the stroke volume, which is made up of the influences are preload, afterload, contractility, wall motion abnormality, valvular disorder. Those are the 5 things that can affect stroke volume. In this case, it was primarily a contractility problem. So the reason our MAP was low, the thing that we were trying to fix in that case, it was a cardiac output problem because the stroke volume was low, because contractility was low. But you can see this works for almost any situation. There are times when your patient's NPO may be diuresed. The stroke volume problem is a preload problem. In left bundle branch block, it's a wall motion abnormality. That's why we are putting a BiV pacemaker in. In MR, for example, it's a valvular disorder. Half the cardiac output is going backwards. So you can see every single time where your blood pressure is low, it is either a cardiac output problem or an SVR problem or both. That's why in sepsis, what do? We treat SVR. Sometimes just after anesthesia, you vasodilate, and it is indeed an SVR problem. However, you do not want to ignore the component of blood pressure that is cardiac output. And you certainly do not want to treat SVR when it is a cardiac output problem. So now let's tie Ohm's law back to the Starling's curve, where we have the cardiac output and we're thinking of stroke volume contractility. Why is contractility down? Well, it's because the shape of our Starling's curve has changed, or the shape of our Starling's curve has changed to reflect what physiologically is going on in the heart. So now, why does our blood pressure drop so often when we give anesthesia? Well, it's because, as we've talked about earlier, you take a normal Starling curve where it says normal function, you give a negative inotrope, and you reduce endogenous catecholamine and direct sympathetic input to the heart, and the curve flattens and you get to a reduced contractility curve. When you're in that reduced state, increasing afterload, which normally is safe, because if you increase afterload, you're just increasing end diastolic pressure and therefore going to increase stroke volume. When you're on the reduced contractility curve, if you give an SVR increaser like phenylephrine, you do not increase stroke volume. In fact, you will decrease it because the heart that's already weakened cannot eject sufficient blood. So while you may get an increased MAP temporarily because your SVR has increased, your cardiac output decreases in response, and your MAP will decrease. Your LV will further dilate, so you'll move rightward on this curve, and you may fall off the right side of that curve and end up in a code. So now we put it all together. The main take home that we need to know is that a heart failure patient has catecholamine dependence. When a patient is in heart failure, that means they have inappropriate ability to generate sufficient cardiac output to supply demand. When a patient's in heart failure, the body knows it and releases catecholamines in response, and they tend to be sympathetically driven in response. They are dependent on that sympathetic and catecholamine stimulation. When we give them anesthesia, it pulls that away. So we must consider, as we said earlier, we must consider anesthesia's negative inotropic effects on these patients, especially when their baseline physiologic status tells us that they won't tolerate that drop. So we have to identify what some of our anesthetics are negative inotropes. Fentanyl, while not a negative inotrope, is a sympatholytic, right? So even sometimes fentanyl, we think that's going to be safe. Well, if a patient if their Starling's curve is only slightly upright because they have sympathetic stimulation, when you give them a sympatholytic, what's the effect? They're going to have a flattening of that curve because the effect will be a withdrawal of a positive inotrope, which results effectively in negative inotropy. Now, sometimes our anesthetics also cause hypercarbia. Did you know that hypercapnia or increased CO2 in the blood and acidosis actually has negative inotropic effects as well, and PA vasoconstriction, as does hypoxia. So we have a lot of these patients whose right heart is weak, or just the right heart tends to fail first in the presence of increased afterload. The right heart is really, really good at increased preloads, at taking a lot of volume, not pressure. It's good at stretching, but it doesn't do very well against a lot of pressure in the PA. So that's why the right heart fails so catastrophically when you have a pulmonary embolus. That's why pulmonary hypertension is such a problem, is because you have a fixed obstruction to the RV, and then when you increase that pressure further or weaken the RV, you can get right heart failure. And so hypoxia and hypercarbia also cause right heart failure because they not only negative inotrope, hypercarbia, but hypoxia causes hypoxic pulmonary vasoconstriction, which further increases the afterload on the right heart. So we also need to be aware there are some procedures that just disrupt normal cardiac function. A pacemaker ICD is one of those sometimes. You end up, as they're screwing the lead in, they get ectopy, or as they're testing the lead, you're pacing fast. Sometimes you pace and come off and you end up with pauses. Think of EP studies or ablations that can cause super fast heart rates. Those heart rates obviously decrease normal cardiac function. It can take a heart that's holding on at rest and put them into a further failure status. So we need to anticipate these things. So when we see hypotension, think, what is the problem? Is it cardiac output or SVR? And then what is the source of that problem downstream when it's cardiac output? Is it stroke volume or is it heart rate? And if it's stroke volume, is it a preload problem? Is the patient just dry? Did they lose all kinds of blood? Is it an afterload problem? Are they clamped down and we're just unable to eject blood? Is it a contractility problem? And if it is, let's think through some strategies. Well, milrinone is a really helpful strategy. And the way that I think about this, I would say if you've sort of tuned out and said Jake's using a lot of big words or this lecture's taking too long, focus right here because this is the crux of the presentation, I believe. Milrinone is a great drug to overcome the direct negative inotropic effects of our meds, of our propofol, of our anesthesia gas. And the reason for that is because it's a receptor independent positive inotrope. Remember, it increases cyclic AMP inside the cell by inhibiting phosphodiesterase. So what do we get? We bypass the beta receptors. These beta receptors are downregulated due to chronic stimulation. And if we overstimulate them, we get tachycardia, which increases oxygen demand and may actually get us to a point where if the heart rate's so fast, we don't have adequate filling and will decrease the cardiac output that way. So milrinone is a great drug to give to undo the negative inotropic effects of our meds. Now, why would we give epi? There are times where, epi is just a really effective drug because it deals with afterload and contractility. But all of our anesthesia, with the exception of ketamine, I guess, causes some sympatholytic effects and certainly anxiolysis, which reduces your endogenous catecholamines. So when you reduce those endogenous catecholamines, give them back. So the way that I think about that is we want to keep our Starling curve just like it was at rest, or as close to it as we could. So we give the milrinone to overcome the negative inotropic effects of our anesthesia. And when we take away catecholamines with our anesthesia, we give them back. So I like to titrate my epinephrine when I use it to baseline heart rate. When you anticipate that your patient's going to have hemodynamic challenges because of either the procedure or their baseline physiologic status, their Starling's curve's already flattened, you're going to anticipate some cardiac output issues. Use better monitoring. So A-line would be great. Great technique is how do we decrease the negative inotropic effects of our anesthesia? We'll use less. So use less anesthesia with these low EF patients. Consider BIS. I run them regularly at a half MAC, sometimes even less in really, really sick patients with a BIS or adding some Versed to it. And then only use norepinephrine or phenylephrine to increase afterload after contractility is fixed. So we don't want to go to these as a first-line treatment because these norepi and neo are fixing primarily alpha. They're fixing primarily SVR. It's an important difference between norepinephrine and neo. Norepinephrine tends to spare the PA. We talked about the importance of maintaining PA vasodilation to not overwhelm the RV. Norepinephrine is better at not vasoconstricting the pulmonary artery, whereas phenylephrine does. So in a patient with right heart failure, give milrinone. Milrinone PA vasodilates. It's a positive inotrope. And then tend to use norepinephrine instead of phenylephrine in those cases. The only alternative to that, or the only rule against that you have to consider is if it's a case where we're trying to maintain central nervous system perfusion. In that case, you may like a carotid endarterectomy or a TCAR, or like if we're doing a thoracic endograft and we need to maintain spinal artery perfusion. In that case, choose neo over norepi because norepi constricts central vessels and neo spares those. So that's extra credit and just something else to think about as we're choosing our pressors. But overall, big picture from all of this is your patient, in this case, coded because we gave them a negative inotrope and propofol. And then we treated hypotension with an afterload increaser instead of something to deal with the reason why the blood pressure was low, which was decreased cardiac output secondary to decreased contractility. All right, last slide. There are some other common out of the blue code reasons where you didn't think this was going to happen. Everything was moving along nicely, and then you code. There's obviously a lot more than we're going to cover here, but here's some other ones that you need to consider. First, let's think about pericardial effusion or tamponade. When you get a pericardial effusion that leads to a tamponade, this is a restrictive problem. The heart cannot fill. It's not a squeeze problem. It is a cardiac output problem, but it's not because of low contractility. It's because of low preload, right? When we look at the it's Ohm's law, it's not an SVR problem, it's a cardiac output problem because the stroke volume is insufficient because the heart can't fill. So no matter what we do, we can't really fix the underlying problem until we drain it. So the main goal is get to drain as soon as possible. Because tamponade, like this says on the first line, decreases preload, which decreases stroke volume, which decreases cardiac output. So what do we do in the meantime? How do we treat it until we get to drain? We'll give epinephrine. Epinephrine speeds up the heart rate. So if your stroke volume is fixed, how can you increase cardiac output? Well, you increase heart rate. Give volume. Give lots of volume. Give blood. Give fluid. Give blood if it's a lot, if you need it, so that you can increase stroke volume if possible, and then decrease PEEP, decrease airway pressures, things that will make the right heart fail to eject blood to the left side. This is a filling problem of the right heart. The right heart can't fill, which means that it's not filling the left, but we need to make sure as much blood is entering and exiting the RA and RV as possible. And so it's critical in this case, if possible, that you actually use negative pressure ventilation. The answer to a pericardial effusion or tamponade is not to tube the patient. If you do, you may code them, because a lot of times you're giving a negative inotrope, last thing this patient needs. And you do not want to slow down heart rate. And then most importantly, you don't want to increase RV afterload, which is what happens when you switch to positive pressure. If you must use positive pressure ventilation, keep those peak pressures really, really low. Another one, what about release of cross clamp? So we do this a lot in vascular. You have a organ, maybe aortic cross clamp, maybe downstream, even just a leg cross clamp. You also get the same phenomenon when you have a thrombotic occlusion, a cold leg, and then you open up that occlusion. You have a limb or multiple limbs in the case of an aortic cross clamp that were malperfused, that sat for a long time with like a complete tourniquet on them. So when you release that, you get vasodilatory shock. The SVR drops. So in this case, you certainly do need to treat SVR, right? Because on Ohm's law, you have MAP equals cardiac output times SVR. You get into a shock state with vasodilation, so you have to treat SVR, right? We see that here on Ohm's law. Now, the other problem is you also, as you vasodilate, you'll lose preload. You're going to need to make sure you have adequate volume. So you're losing preload, you're losing afterload. You can get acidotic from all the waste products, lactate and whatnot, coming back into the systemic circulation. That can decrease contractility. So your cardiac output drops as well. So you can get profound hypotension with release of cross clamp because both cardiac output and SVR are down. So what do? Well, you give preload ahead of time. Volume resuscitate that patient aggressively prior to release of cross clamp. Like I said, you can get myocardial depression, you can get electrolyte abnormalities, all dysrhythmia triggers. So you're actually decreasing not only contractility, but you can have wall motion abnormalities from electrolytes or straight up VT. How do we treat it? Preemptive volume load in anticipation of release. You should never go into cross clamp release on pressors if at all avoidable. Catch up ahead of time. Volume resuscitate, get off your pressors. Preemptive hemodynamic optimization is just what I was saying. Correct acid, base, and electrolytes ahead of time and then anticipate needing to correct them after cross clamp is released. A lot of times as cross clamp is being released, I will push an amp or two of bicarb. Also hyperventilate that patient in advance. Make sure you're choosing the right treatment for the job. The the answer is not, all right, just push a ton of neo or go into the cross-clamp release on norepinephrine. You need to optimize and then treat the problem at hand, which will, like I said, likely be acidosis correction, volume resuscitation, afterload increase. And as you know, if you're in acidosis and none of your pressors are working, vasopressin is a good choice to go to here because it tends to work even in profound acidosis. All right, another one. What about aortic stenosis? Aortic stenosis is a different kind of beast. As you know, coronary perfusion pressure, so that's the blood pressure that's filling the coronary arteries. Coronary arteries fill during diastole. So it's not MAP that's driving that flow, but it's the mean aortic diastolic blood pressure. And then what's the pressure that's keeping the blood out of those coronaries? Well, it's the LVEDP. And for the right heart, it's the RVEDP. So the things that will tend to drive your coronary perfusion pressure down to zero and make your heart not get any blood flow is either a drop in afterload or an increase in end diastolic pressure. Unfortunately, aortic stenosis in and of itself causes an increase in end diastolic pressure. That's why there's such a problem here. So we need to make sure that we don't exacerbate that, and then most importantly, that we don't lose afterload. So anytime when you have aortic stenosis, the answer is not epinephrine usually. It would be more like phenylephrine. Keep that afterload up and avoid tachycardia that would further compromise coronary perfusion. Unfortunately, after you lose afterload and your coronaries are not perfusing, these patients are unable to, you can't really resuscitate them successfully using compressions because you're trying to eject blood out past a fixed obstruction out of the aorta. It's really, really hard to get these guys back. A good first line, if you realize they're about to crump, is calcium. That increases contractility, helps get that LVEDP down, gets the blood pressure up quickly, and avoids tachycardia. I hope this was helpful as a way to think about rather than just respond to low blood pressure, and to think about and anticipate rather than merely respond to patient decompensation. If you have any questions about this, or if you face any situations where you need guidance thinking through a problem, please don't hesitate to call me or text me. Write this number down. Put it in your phone. Please don't hesitate, if you're a guide provider anywhere, to reach out. And I'd love to talk through the scenario with you to help make sure that your patient is getting the optimal care, especially when they're going to be hemodynamically compromised.